Good evening, everyone. Thank you for coming. For those of you who don't know me, I'm Dave Burmeister. I'm the chair of emergency and hospital medicine here at Lehigh Valley Health Network. And I just want to say thank you to everybody for coming, and because this is a really important initiative for us in the network. You know, over the past couple years, and I would say over the past 10 years, we've done a pretty good job at trying to take care of our patients, and I think that we continue to do that, and we continue to want to try to get as good as we can and constantly get better. And this year, we actually, with Matt's leadership and some other people's leadership within the network, we have been able to really improve our mortality, for our expected mortality within the network, and I think that that's a really important point to make, and we've come a long ways just in 1 year. One thing that we realized over the past year was that our sepsis mortality wasn't really where we wanted it to be and wasn't where it had been over the previous 2 years before. And so we really wanted to kind of take another look at mortality for our sepsis patients to try to figure out how we could do a better job at taking care of them. And all of us have a lot of history together. Probably every person in this room has a history with us at LVHN. And some of the biggest success stories that we've had here for our patients in this institution has revolved around EMS and how they've interacted with the emergency medicine and how emergency medicine has interacted with the rest of the network. Two of those really great examples are door-to-balloon times. Our door-to-balloon times in 2007, before we started really getting EMS involved in our pre-hospital MI alerts, our door-to-balloon times were, if we were lucky, greater than 60 minutes. And when we started to really educate, and I can remember lots of faces in this room here that I'm looking at, when we went to start to educate the EMS providers on our pre-hospital MI alert, what it would look like, and how you gained ownership of the outcomes of our patients, that's when we really saw a huge benefit. And we got our door-to-balloon times down to around the 40-minute range, which was incredible, unheard of. Absolutely unheard of before we got EMS involved in our pre-hospital MI alert program. Then came stroke, right? We were doing pretty good. We thought we were the best. We thought we couldn't probably do any better, right? We thought that we were at the top of our game until we went to town hall meetings and listened to you. And you told us, you said, you know what? You're not paying attention to what we have to say to you. We could really improve our times by just paying attention to our pre-hospital providers telling you that we're bringing in a stroke alert. So what do? We got a group of people together, and we developed a pre-hospital stroke alert. And what did? We improved our times significantly. Our door-to-TPA times were incredibly improved once we got EMS involved in what we needed to do, which is just only two examples of how we've improved the care of our patients, and we provided a whole other level of standard of care for our patients. So first of all, I want to thank you for all of that. And second of all, when we started to talk about sepsis and we realized that we have so much opportunity to improve, the first thing that comes to mind is who do we get involved in this process? And that's our EMS colleagues. And so that's where this came from. We know we need to improve our sepsis mortality rates. We know we want to improve the care of our patients. We know that many of our patients start with you. And by starting some of this education, not that you don't already understand a lot of it, but getting us involved together with a process and put it in place, just like we did with the MI alert, just like we did with the stroke alert, we feel very confident that we can really make a large impact on our mortality for our sepsis patients. So again, this is one of many education sessions, and this is just the beginning. It doesn't mean that we can't change and tweak things. It doesn't mean that we can't change some of the criteria. Maybe some of the things that we put into place originally might not work. We might find that out in 2 weeks. Maybe it's a month. But we need your input to be sure that we're doing the right thing for our patients, because you're the ones that get there first. And so there's a lot of work that's going to be done. I want to thank Matt. I want to thank everybody in this room. Marianne, thank you so much for getting the group together. Keith McCucci's been instrumental in putting us all together as well. Rick McKenzie, thank you. Matt, thank you. Everyone that's been involved in this project. And more importantly, thank you for being involved, because if you're not involved, it doesn't work. And we've seen that before in the past. So at this point, I want to just make sure I give this to Matt. He's going to talk about the process, And remember, we'll work together to make sure that it's the best it can be. Thanks, Matt.
Okay, thanks for the introduction. That was great. Okay, so that's fantastic. All those people, there's been so many people that have helped with this program, and that's exactly what happened. We started talking about sepsis about 5 months ago now, and Dave pulled me aside and said, yeah, you got to talk to the EMS guys. And then I talked to Keith, and he said, you really got to talk to the EMS people. And then Marianne echoed that, and so we've been working on this, but this is a really important night because it really does start with you, and I'm going to explain that in a second. There's another person who's been really intimately involved in this from the ED side of things, and that's Dave Richardson. Dave Richardson, if you know him, he's an ED doctor. He's been here a lot longer than me, and he's been intimately involved in this along with Marianne and Keith and Rick and Dave back there in the back. So that's the ED team. And then this is my team right here on the slide. So I'm Matt McCambridge. I am actually the chairman for critical care at Lehigh Valley Health Network. I've been the chairman here for 10 years. I'm also the medical director for quality and patient safety, and that's a new thing I've been doing for about a year. And these are my team members below my name there. That's Tony Ardiri is actually the senior vice president for quality and patient safety, so he's my boss when it comes to these types of things. Chris Deschler, I think, just walked in the room. Yeah, there she is back there. So she's like a program manager here. She works in the quality department, and actually, it's a funny story. I'll tell you in a minute why all this started. B. Ortner is sitting right next to her. B is also on the sepsis team, and none of this would have happened without Carrie. Carrie Vincent is our project manager for this, and she is unbelievable with respect to her organizational skills. So I'm a big picture person, and she is in the weeds, and I'm not exaggerating by saying that it had been really hard pulling this off without Carrie keeping us all organized through this whole thing. And so that's the background of all this. I'm a local guy. I was born and raised in Allentown. I spent 13 years in the United States Army, used 82nd Airborne Division, and I've been home here now for 13 years also. So we're going to go ahead and get started. So we're going to talk about the background, how we're doing locally and nationally, something that's happening outside our network, and then future steps. This is what got the whole thing started. This is our mortality graph. And when you're involved in running a big network, you got to know how you're doing every month and every quarter with respect to your mortality. And the mortality is rated as it's observed over expected mortality. So if I get admitted to the hospital right now, you can calculate, looking at a lot of parameters, what my expected mortality is supposed to be. That's the denominator. And then the observed mortality is actually how you're doing. So this graph right here, back in 2008, the third quarter of 2008, was second best in the entire country with respect to mortality. 5,723 hospitals in America. We were second best in the entire country at mortality. And a lot of reasons. You guys played a big role in that. And then you can see what happened is this is observed over expected. Back then was 0.63. And then it started gravitating kind of in the wrong direction. We put a trend line to it, and then this is what got everybody's attention. This is when I got a kind of an email from somebody higher up than most people. And said, we got to start thinking about this. And since that time, we've started focusing on mortality. This is our observed to expected mortality over the last several months. And now I'm happy to say we're back in the top 10 in the country with respect to observed or expected mortality. That meaning that if you get sick, this is a really good place to get sick because chances are pretty good we're going to save your life. During this process, and the way we did that is we developed internally in the hospital something called a hospice response team. As you know, because you bring them to us, about 7,000 patients a year get transferred from outside hospitals, and many of the patients come here, and a lot of them we can't help. We evaluate them, and they have catastrophic problems, and we can't exactly bring them through. Many of those patients, the best thing to do for those patients is do the big evaluation, have somebody like Mark Lee or a neurosurgeon come and see them, and then place them into a hospice situation. And that's been one thing that's come out of this whole last year, is this thing called the hospice response team. We've got very favorable feedback from our family members in the community. We've also gotten better over the past year with physician documentation. Doctors writing down how sick the patients are, and we adequately reflect how sick the patients are, the expected mortality goes up. Those were actually the easy things that we did. This was the email that stopped me in my tracks 2 days before Christmas, which isn't a great time to get an email like this. But my boss, Tony Ardiri, had been kind of whispering in my ear for about a year that there might be something up with sepsis. So I'm going to walk you through this slide. And again, understanding this whole concept of observed over expected. This is the University Health System Consortium. The University Health System Consortium is 134 of the biggest hospitals in America. So think of Johns Hopkins, Massachusetts General Hospital, UCLA, UCSF, University of Iowa. Big, big, big hospitals. This is the septic shock mortality, the sepsis mortality index. And the UHC median number was 1.08, which means that the whole country, when you look at septic shock, doesn't do a particularly good job. More people across the country are dying from sepsis in these big hospitals than should be. 1.08 signifies that 8% more people are dying than should be. Well, the problem was, back then, this is the email I got from Chris Deschler, our observed to expected mortality rate for this one diagnosis was 1.42. So many patients with sepsis and septic shock were dying that shouldn't be dying from septic shock. And we think that maybe as many as 96 cases during this time period, over the period of that year, were dying from septic shock. And then Chris broke it down for me a little bit further. These are July, August, and September of 2015. The number of cases, 442 cases, how long they stay in the hospital. The percent of them that are admitted to an ICU, as you can imagine, 70% of them are admitted to an ICU after you bring them to us. And then over here is the mortality index, again, observed, divided by expected, 1.38, 1.17, 1.33 for an average of 1.29, higher than it should be. It's bad nationally, but we were particularly not where we wanted to be. Okay, so then we broke it down. We looked at our overall mortality index down here, this graph. And you can see our overall mortality for the last several years has actually been quite flat. But our sepsis mortality is going in the wrong direction. Our all-cause mortality rate over the last 10 years has dropped to 1.5%. 1.5% of the people who are admitted to the hospital after you bring them to us will pass away. That's 1,025 patients, 55,000 admissions per year. And you can see that our all-cause mortality rate, if anything, it's kind of flat. But this is our sepsis mortality rate, and you can see that we're doing quite well with respect to our sepsis deaths until the end of 2014, and then they started going in the wrong direction. This is I like this slide, it's one of my favorite slides. And this slide shows the impact of septic shock in the community. So think about it, there's 1,732 cases of septic shock per year that come into our doors. You actually bring us half of them. And this says that when the septic shock mortality is low, the overall mortality is low, and when the sepsis mortality is high, the overall mortality is high. 341 patients died from sepsis last year in the institution. That was 33% of all deaths in the institution. And that's why we're focusing on it so much. That's too high of a death rate for one particular diagnosis, 341 cases out of 1025. Kind of morbid. I know this is a little bit morbid, but we really started looking deep into this, and this is where we realized that we have a pretty big opportunity looking at this one particular diagnosis. Okay, so this is where you guys come in. We divide septic shock into what's called present on admission or not present on admission. Present on admission means they come into the emergency department with it. Either you bring them in or they got in by themselves, but Rick and Dave Burmeister and all these people and you are bringing them in and taking care of them. And the observed to expected mortality ratio in 2012 was good. It was 0.7, meaning fewer people than dying than were supposed to be. And then you can see it snuck up over 1.0. It's really bad, the mortality index, if the patients are admitted to a floor or they develop septic shock on the floor. So it was 1.1 for present on admission, what we call present on admission. But on the floor, it's 2.5. Very, very high. It's fewer numbers of patients. You all bring in the bulk of the patients, but if they sneak through the ED and we didn't figure it out when they were in the ED and they land up on the floor, Different type of focus up there, different kind of doctors, not ED doctors, not ICU doctors. Nurses there's a lot going on up there. It's a problem if they sneak through the emergency department. This is surgical volumes. This is a funny graph. Again, the wide variation is because there's not as many surgical septic shock cases per month. And that's why the variation looks so bad. It's the same general idea though. If you don't come in through the emergency department with you all working on them from the get-go, and then the ED doctors taking over, the ED nurses taking over, and you develop septic shock from a surgical issue in the floor, it's a very, very high mortality. This is a review. I think you might be familiar. The Journal of the American Medical Association a couple months ago redefined sepsis for they call it sepsis and septic shock. We're going to stay with the old definition because we get graded on the old definition by the government. And the old definition is SIRS, systemic inflammatory response syndrome, sepsis, severe sepsis, and then septic shock. Septic shock is easy to understand. I think you all see a lot of this. This is refractory hypotension. A couple liters of fluid, you're starting pressors, and these people are powerful sick. Sepsis with organ failure, and then SIRS with a confirmed infectious process. Okay, so one of the things that's nice about information these days is it's fairly readily accessible. And Carrie, Chris, and B, was all four of us at the IHI? Yeah. And I was tired, and Chris kind of drugged me to this lecture, and I was ready to go home. And this was down in Orlando, and this guy from North Shore, Long Island, Jewish, the head of the ED there, just kind of blew me away. And so they had, you may remember back in 2005, we actually had a sepsis alert process. But that was back when we were in private practice and we didn't have a staff very well, and we kind of fell by the wayside. Back in 2008, they put together a sepsis alert process at North Shore, Long Island. Michael Dowling, the CEO of this system, said that this was their #1 priority for the year, and this is our #1 priority for the year. They formed their sepsis task force in 2009. We're forming ours in 2016. And what they found was that sepsis was this continuum between sepsis, severe sepsis, and septic shock. And then they did all the things that we're going to do here, which I'm going to describe to you in a minute. Lactate, organ dysfunction, and SIRS criteria. And what they did over the period of years, this is a really interesting control chart. And they started with a mortality rate 32%, you can see 36.5%. And then they formed their task force, ED algorithm implemented, and then they dropped their mortality all the way down to like 12.5%. And that's what we're hoping to do with your help. Really, really interesting is that it's all about early fluids, drawing a lactate, and early antibiotics, as early as you can possibly do all these things. No different than MI, alert, stroke, all the other things that you guys do so well. The faster you get the fluid, the less chance they are of dying. So if you don't get the fluid within the allotted time, 30 minutes, and then greater than 30 minutes, there's a 75% chance you're going to die. This is another hospital, Mount Sinai sepsis mortality rate. Mount Sinai is in New York City. Same problem, right? 32% sounds an awful lot like us. They put their task force together, and then they optimize their program, hospital-wide expansion. We're going to go network-wide expansion, Cedar Crest, Muhlenberg, Hazleton. And this is what we did. We put together this task force. This is many more meetings now. We've met 30 times in the last 3 months. And Keith has been involved in a lot of those meetings. This is our whole task force. All people seriously interested in reducing the sepsis mortality. You can see a lot of the names you might recognize. It was broken into present on admission and not present on admission. Then the present on admission, which is what we're asking you all to focus on, was group 1A, B, C, and D. We looked at flow diagrams, sepsis order sets, laboratories, education, transitions of care with the residents, reporting and feedback, which is an important thing that Orlando's been working on for years and years and years that we're going to apply here. And then this is you guys, education for EMS staff, and the whole pre-hospital component of this. Okay, so that's the kickoff. That's why you're here tonight. That's why we're focusing on this. You know, I can't thank you enough for your time. I know how busy you are in your personal lives, and Matt's going to take it from here.
Yep, there it is. Okay, it's just this right here, right?
That's
Forward.
It.
Okay, so I don't know. Probably nobody knows me. I'm Matt Neos. I'm one of the third-year ER residents. hopefully one day maybe I'll do a critical care fellowship. So that's sort of how I got wrapped into doing this program. So if you see me in the ER, if I was rude to you, I apologize. But so they asked me to talk about what is sepsis, and this was sort of my reaction when they asked me to come up with this presentation, because this is not an easy topic to talk about. It's not something easy to explain to people. So I sat in my apartment and rocked in the fetal position for a little bit. And then I decided to go back to the basics and think about what is a good thing to talk to you guys about to try and determine what sepsis is. And back, I don't even know when this was, Dr. McCambridge probably knows the dates, but when the Surviving Sepsis campaign came out, I think in the early 2000s, they came up with a pretty good definition on how we classify sepsis, going from sepsis to severe sepsis to septic shock. It can be sort of nebulous and difficult to understand, but probably the most important thing to impress upon you guys is this last sentence right here, which is similar to polytrauma, like the code reds, trauma alerts you bring in, MIs, stroke alerts. It's the early aggressive therapy is what's going to affect people and decrease their mortality, and that's really what we're looking to do here, is look to identify these people in the pre-hospital field, get them the treatment that they need, and let us know in the ER that they're coming so we can continue that treatment along and try and reduce their mortality and help network-wide initiative out. So the big picture, and this is a slide that you guys saw earlier, is what is sepsis? So sepsis starts with infection, then you get some sort of systemic inflammatory response, which is the SIRS criteria, which you'll hear a lot about. Then it goes on to sepsis, which is the SIRS criteria plus infection. Then you can progress to severe sepsis, which is sepsis plus one or more organ failure, and then you go to what we all recognize pretty easily as septic shock, which is that lady from the nursing home with the urinary tract infection who's tachycardic, hypotensive, very febrile, ends up in the intensive care unit, probably intubated. So these are really easy to recognize. It's sort of this category right here and this category right here that are pretty more difficult to explain and can be actually very difficult to tease out when you're seeing these patients. So what sepsis is not, sepsis isn't just the simple infection. It's not just a little bacteria that comes along here, causes maybe a little cellulitis, a urinary tract infection. Normally, if you or I were to get this, we just have our immune system would kick in, maybe we get an antibiotic from the ER, and then we're all happy. We go back to doing what we normally do every day. So this is what normally happens. This is not what sepsis is. Sepsis is not just a simple infection. So that's my take-home point number one for you guys. Sepsis is a true or suspected infection in addition to systemic inflammation. And like I said, it's a really poorly understood disease process, and it can be very difficult to tease out when you see these patients. And it's not like the MIs or the strokes, which is what makes it so difficult. It's not like when you see this EKG with ST elevation and 2-3 AVF, oh, inferior wall MI alert. It's not like the person you see that's got right-sided hemiplegia, oh, it's a left MCA. You know, it's not as easy to pick out. So that's what makes this truly difficult to understand and sort of wrap your head around. So like I said before, it's systemic inflammation plus infection. So how do we determine if people have systemic inflammation? And we use these criteria called the SIRS criteria, and this is sort of what we base the whole pre-hospital identification of these people on. So it's body temperature, 38 degrees Celsius, greater than 38 degrees Celsius, and it's also hypothermic patients too, so less than 36. It's a heart rate greater than 90, so it's not, the typical tachycardia is greater than 100, SIRS criteria uses 90. It's tachypnea, which is probably the earliest manifestation of anyone with sepsis, is their breathing. They kick it up greater than 20. We're probably not going to be measuring ABGs. You guys are not, so you could probably disregard that one. And this one's also difficult. It's the white blood cell count. You need labs for that. So the big ones to remember are temperature greater than 38, less than 36, heart rate greater than 90, and respiratory rate are the big SIRS criteria that you guys will probably be utilizing in the field to identify these patients. And then it's SIRS criteria plus a true or suspected infection. So if someone says to you, I've been coughing, I'm bringing up green, red colored sputum, it really hurts when I go to the bathroom, I'm having diarrhea, abdominal pain. And then in the hospital, we use positive blood, urine, and sputum cultures to confirm that there is that true source of infection. We get a chest x-ray, confirm that there's an infiltrate. But it's really in a good history that you determine, like, you know, anytime that we get sick, we have the same symptoms. So you can apply that to the patients that you're seeing too, to sort of determine if these people have sepsis. So again, it's these SIRS criteria plus, do we think they have an infection? If the answer to that is yes and yes, then they probably have sepsis, or they could have sepsis. And that's what we want to know when they're coming into the hospital. So take home point number 2 I have for you is sepsis is systemic infection plus systemic inflammation. And so the normal physiology is we have our little bacteria guy coming here. you get your systemic inflammation, but then something goes wrong. This is when you start having sepsis, you start having that systemic inflammation, you get some vasodilation, you get a little low blood pressure, your cardiac output drops. Then we compensate, most of us compensate, and that's okay. So our heart rate goes up, we get a fever, we start breathing faster, which I have here. We start breathing faster, our white blood cell count goes up, and then most of us get better. And that's good, but some people don't, and then they progress along. And so we want to intervene on these people to prevent them to progress. So when we lose our compensation, we lose our success, and this is when we need to intervene and help these people out. So when our compensatory mechanisms fail, you get this circle that keeps going and going and going. You get your inflammation, you get vasodilation, hypovolemia, low cardiac output, and then you progress along to that severe sepsis, where now your organs are being affected. So you have one or more organs affected as a result of the infection that you have. So my take-home point number 3 is severe sepsis develops when normal compensation is lost and inflammation starts going unchecked. Now it's affecting your organs. Now we really need to be aggressive and treat you to prevent it from going to septic shock, which is what we don't want to happen. So severe sepsis, like I said, loss of compensatory mechanisms, you get persistent hypotension, you get low cardiac output, so now your heart rate's going to be going faster, trying to pump all that blood throughout your body, persistent inflammation, you get impaired oxygen delivery and utilization throughout the body. This is where your lactate comes in, so now you're not getting oxygen to your tissues, so now you have anaerobic metabolism, your lactate starts going up. The end result of all of this is ultimately you get some organ dysfunction, so your kidney function can go down, you have that altered mental status, and then this, like I said, can progress to septic shock if not treated, and that's what we want to do. And this is the whole In the Surviving Sepsis campaign, like I talked about. They list all these forms of organ dysfunction that you can be having. This is how we diagnose people with severe sepsis. So you get low blood pressure, your lactate starts going up, you have decreased urine output, you can have some sort of lung injury that we see mainly in the ICU, like ARDS, renal function is increased, platelet counts go down. These are all things that we measure in the hospital that we obviously wouldn't be expecting you to identify, but it's really the identification of a patient with sepsis, letting us know so we can have heightened awareness to them in the ER, and you guys can start treating them early enough and getting them the fluids that they need, and then we can be getting the antibiotics early when they arrive to the hospital. So severe sepsis is defined as sepsis plus new organ dysfunction or evidence of hypoperfusion. And then my take-home point 4.5, and this is going to be a big point for you guys, is using the EndTidal Co2. Because as we talked about, lactate moving up is a sign of organ dysfunction. That's a big thing that we measure in the hospital and trend in the hospital. So I think Mary Ann will talk a lot about it, but using EndTidal Co2 correlates with increased lactate levels, and that correlates then with organ dysfunction. So knowing that when they arrive to the hospital, we know this patient is probably a lot more sick than they actually appear to be on the surface. So like I talked about, sepsis is not just a static process. You don't get sepsis. We want to prevent people from getting here. It's a continuum, so people start with SIRS, then they progress to sepsis, then they progress to severe sepsis, and they progress to septic shock. We want to try and stop them right here and prevent them from getting to severe sepsis. And if they are there when they arrive, we definitely want to prevent them from getting the septic shock, because your mortality rates drastically increase as you move along this continuum. So if they're here, we want to sort of move them back here, and then obviously get them better and get them home. So sepsis is a disease continuum. Early intervention is key to prevent progression along this continuum. And then important pre-hospital interventions, like we talked about, is letting us know that you have someone with sepsis or presumed severe sepsis, using the SIRS criteria like we talked about, saying that they have a known infection, they were just in the hospital and we know they have a urinary tract infection, or they have signs of an infection like cough, sputum, urinary frequency, and then giving them the fluids that they need. All the studies that have come out recently and all the studies in the past show that early fluid administration and early antibiotics are what really help these people. So even before they get to the hospital, you guys can do a lot to help them out by giving them a fluid bolus, letting us know how much fluid you gave them so that we can either complete their initial 30 cc's per kilo bolus, or knowing that, hey, this person already got 2 liters, they're still really hypotensive, we better just start them on vasopressors and get them to the ICU and get them antibiotics. And then letting us know that they're coming in. So we're there available to talk to you at bedside and know what we have to do.
First of all, I just want to thank all of the pre-hospital providers. I think from the very moment that we started to talk about pre-hospital sepsis, we had a lot of excitement within the pre-hospital community. So I can't thank you folks enough. So the other thing that I'd like to do right now is acknowledge some of the people who are on our pre-hospital committee who have been working diligently. We started back, Keith, where are you? We started back, in January meeting, and we've been meeting every 2 weeks, every Monday, 10 o'clock, and we vowed that we would get our pre-hospital sepsis alert running by May 1st. So I'd like to acknowledge Keith McCucci, Amy Grill in the back, Sean Silvoy. Where's Jeff Hoffman? Jeff Hoffman, Dr. Niehaus, he's been really supportive of us. Riza from the ER, we have a lot of the ER staff. We also have Matt Markle from Upper Saucon EMS on the committee, as well as Eric Bratz from the city of Allentown. So I really have to thank everybody for all their enthusiasm and all their hard work that they put into this. So we talk about sepsis. What is sepsis? It's a global problem, and sepsis has a high rate of death. When I first started thinking about sepsis, I thought, wow, this is really only a third world problem. These other countries, they're the ones that are succumbing to these infections. But listening to Dr. McCambridge, I didn't realize what a national problem it is, that people are dying throughout the country. Despite the advances in modern medicine with vaccines, antibiotics, the high level of care, the sepsis deaths in the country are still pretty astounding. And we looked at, in the United States last year, more than 750,000 cases of sepsis were documented. And more than 210,000 people died. So about 30 to 50% of the patients with septic shock will succumb. And what's amazing is EMS transports far more patients with sepsis than they do patients that are MI alerts, stroke alerts, or even trauma alerts. So, I thought that was pretty astounding to find that out. So during this presentation, while you're sitting here, 90 people will be diagnosed with sepsis in this country. And 20 patients throughout the country will die as a result of sepsis. So how can you, the EMS providers, play a major role with sepsis? It's going to be early identification of that patient, as well as starting care right away. As Dr. Niehaus mentioned, really IV fluids administration is going to be key for that patient. And early ED notification, which is why we're putting together a pre-hospital sepsis alert. May 1st, it's going to be implemented here. What's interesting, has anybody here called a pre-hospital sepsis alert yet? I know there's been a couple of people, a couple of services, and I've got to, say congratulations, because you're really excited about this. Unfortunately, we have not rolled it out yet in the emergency department, but as of tonight, I think Dr. McKenzie, were all the ED docs notified that it will be implemented May 1st? So we have a very, very aggressive timeline. Oh, Keith took credit for that. Okay. So thank you, Keith. Okay. So what is Lehigh Valley Health Network doing to improve care, patient outcomes with sepsis? Well, Dr. McCambridge had a slide up there that showed you. We have 4 different committees that have been put together, have been working diligently since January to address the outcomes here within our network with sepsis. So over 100 people are on that. We have EMS providers that are involved with the education. And that's why you're here tonight. We want to educate the EMS provider. I will tell you, I am guilty, and I'm sure many of you, where you get dispatched to the nursing home for the UTI, and what care do we give for that patient typically? Maybe oxygen, okay, maybe a blanket, and we typically, just transport them thinking it's just another nursing home patient. But a lot of education will be going on. So implementation of our PSA, pre-hospital sepsis alert, is scheduled for May 1st. This pre-hospital sepsis alert will be a work in progress. There's a lot of different phases. The ED is putting together their algorithm for what will be put into place, but it's a work in progress. Bear with us. Everyone is aware the pre-hospital sepsis alerts are coming, but there's a lot of different phases. So just because maybe the first month, 2 months, you don't see a difference with the reception, we're gonna get there. Okay. Anybody remember the pre-hospital stroke alerts? Were they a little difficult to get off the ground? It took time, but I think we have a pretty well greased wheel now, well-oiled wheel. So we're going to get there with sepsis, but we need the help from you folks with this. So who are the faces of sepsis? Sepsis does not discriminate. It affects all age groups. And it's not respectful of lifestyle choices. So who's the most at risk? We know our newborns, young children, patients that are immunocompromised, patients with chronic pre-existing conditions. You might have the patient with diabetes. Patients that are trauma patients, they are subject to become septic. Nursing home patients. Those patients who have indwelling catheters, might be a urinary catheter, might be a patient who has a peg tube, a feeding tube, or maybe a patient with a tracheostomy. All of these patients are at risk for developing sepsis. Anybody tell me who this is? Was just in the news, maybe within the last 2 to 3 weeks, she died? Patty Duke, okay? What did she die of? Yeah, died of sepsis. What was wrong with her, Tim? She had, I think, a ruptured bowel or something to that nature, but in the news, sepsis. And does anybody know who this is over here? Christopher Reeves. Now, why would he be one of the faces that is prone to develop sepsis? Yeah, he had a trach, okay? So sepsis does not discriminate. Anyone, any age, any ethnicity is at risk. So what is the economic cost of sepsis? The majority of cases are acquired within the community. We also have cases that are acquired within the hospital setting. But within the community, that's why we need you folks to do that early identification and treatment of sepsis. And we know that it can save lives. By you initiating care, identifying that patient early on, and giving us the heads up, you are increasing that patient's odds of survival. So we can really do this job together if we all work as a team. And we also know that early identification and treatment is going to decrease the negative impacts that come along with sepsis. This is pretty interesting. This is, I just heard the other day, wasn't it? Within 3 months of discharge, 40% of the patients are readmitted, and they're more costly and risky with each admission. So here in the United States, in the state of Pennsylvania, the #3 cause of hospital readmissions is sepsis. So it's really a big thing for us that we're taking seriously here. Septicemia, it's the most expensive condition to treat in U.S. hospitals. And in 2011, the United States, we spent $20 billion on treating the septic patient. So really, sepsis is a big thing. So we know that most patients with severe sepsis, they typically recover completely. Permanent organ damage may occur, though, in patients with pre-existing chronic diseases. For example, you may have a patient that had some type of kidney impairment, and as a result, sepsis can lead to kidney failure for that patient, and they may then have to go move on to lifelong dialysis. So really, it's a severe illness that we need to be aggressive with treating. and it can cost a lot of money. For that septic patient that winds up developing a chronic organ damage, the medical care out of the hospital is going to be substantial. So they'll have to have money paid out for the follow-up treatment. They may have a great length of delay going back to work, so there's no income coming in. Or what if they can't go back to work at all? And then we have the need for the family to change their lifestyle, and it may be many, many years of rehabilitation that that patient now is subjected to going through. So 80% of the cases of sepsis come through emergency departments across the country. And last year, here at Lehigh Valley, approximately 1,732 cases, I think, Dr. McCambridge, presented. That relates to roughly about 5 cases a day. For those of you with the calculator, it actually comes out to 4.74 patients, but we'll round her up to 5. So sepsis care is really a team approach with all of us. So when we talk about identifying sepsis, for EMS, early detection is important. For the patient having the MI, how do we know they're having an MI? What do we have to help us? Your 12 lead, right? If you have a patient who's diabetic and we think they might be hypoglycemic, what do? Do an AccuCheck with a glucometer. So we have some things that can tell us what's wrong with the patient. Sepsis is different. It's really a conglomerate of signs, symptoms, and vital sign changes that occur. Patients can be in septic shock and not be showing any types of outward signs. Their blood pressure might be, fine, but internally, they're actually going into shock. And elevated lactate levels are an indicator of shock. Now, I know some folks have asked, are we going to be doing the point of care lactate levels? And the answer is no. There are a few EMS agencies throughout the country that are doing it, but really we don't have any approved lactate point of care machines that can be used for EMS. They're out there, but they're typically used by EMS by athletes. So we know that with our organ dysfunction, we have greater than 2 to 2.5 causes organ dysfunction with lactate levels, and greater than 4, that patient is in septic shock. So Dr. Niehaus went over this about the different stages of sepsis, but the important ones for us to remember, and I think, did everybody pick up the cards? I had some reference cards made up for you. What you're going to be looking for, 2 or more of the SIRS criteria, we have temperature greater than 38, which is 100.4, or less than 96.8 degrees. Heart rate greater than 90, and your respiratory rate is going to be greater than 20 breaths. So this is the criteria you're going to look for that patient. So when we talk about sepsis, how do we know if the patient has any type of infection going on? We've got to be the private eyes, the investigators. We take a look. You want to, for the patient that's bedridden, what are they prone to developing? Yeah, bed sores, pressure ulcers. So you want to take a look. You want to examine. You want to check the places dependent, their sacrum, their heels. So you want to take a look at those patients. What about the diabetic patient? What are they prone to developing? Yeah, they get foot ulcers, okay? Patient with cellulitis. We see that commonly on the legs. They may have it on the forearms. But these are the patients with skin infections you want to take a look and you want to delve into. The respiratory system, most common site source of an infection. So what do you want to ask your patients if you suspect some type of a respiratory infection? What are you asking them? What's that? Yeah, what color is your sputum? Do you have, are you having a cough? Have you had symptoms of an upper respiratory infection? Any type of ear pain? You know, GU complaints. What kind of things are you asking the patients about? Are they experiencing urinary frequency, you know, pain? Do they see any blood in their urine? Are they having any trouble urinating? So these are the things you want to ask. You've got to ask, get a good history with these patients. We know the GI system. If a patient has diverticulitis, they may have an infected diverticulum. Ask about nausea, vomiting, you know, bowel movements. You want to go ahead and assess the abdomen. You want to palpate it. Any signs, you know, of any distension, firmness. So really, we have to do good physical assessments on these patients. Musculoskeletal infections, not a common source of infection, but again, joints can be affected. Is there any pain, redness? Do they have pain with range of motion? So you want to go ahead and assess all of these different sources. So we talk about the pre-hospital treatment. We want a thorough history and a clinical exam for these patients. Ask about any current or recent antibiotic use with them. Ask about antibiotic allergies, because if we can find out what these allergies are early on in, we can plan our care better on the emergency department side. You want to go ahead and manage your airway, ventilate if needed, keep your end-tidal CO2s around 35 to 45 if the patient is intubated. Otherwise, we get the patient on high-flow oxygen. Maintain warmth. Even if the patient has a fever, keep that warmth in. Hypothermia can also be another sign of sepsis. As we said, a low temperature, you want to maintain the warmth. And things we can use to maintain the warmth, we can use blankets, obviously, warm IV fluids. How many people typically start warm IV fluids on their patients? A couple people, okay, and that's good. Normally we pull them out of our box, off the shelf. But again, if you have that patient who's in shock and now you're infusing room temperature IV fluids in, what's room temperature? About 72 maybe? What's body temperature typically? 98.6. Can you make that person now hypothermic? They can develop cold stress. They can become acidotic. So for these patients, we're looking that you infuse your warm crystalloid fluids. You want to get a full set of vital signs, and what we're incorporating with vital signs for these patients is going to be your end-tidal CO2. Very, very important. We also want temperatures on patients. Ideally, tympanic is not the way to go. We're looking at oral. I know they do have some of the temporal artery thermometers that are out there, but they're not always very accurate. And if the thermometer itself is cold, it's going to give you an inaccurate temperature of that patient. And we also, when you call in for medical command, give the weight, the estimated weight in kilograms for that patient, because that's going to be really important for your fluid resuscitation. You want to get your vascular accesses. You have a patient septic shock. We're going to ask you for 2 large bore IVs and infuse your IV fluids. Also important is making sure that you get a blood sugar on these patients. Because of the cascade of events that occurs with the patient who's septic, a lot of times they become hyperglycemic. So again, getting a blood sugar on these patients is important. So we talked about first thing we're going to want you to do after you get your IV in, whether it be or an IO, is infuse 500 cc's of warm normal saline rapidly. After each 500 cc bolus, you're going to want to reassess your patient. If there's no signs of CHF, repeat the boluses up to 2,000 cc's or until you get a blood pressure greater than 100 systolic. Contact medical command as soon as possible. And, you know, folks are saying, why do we have to call medical command? This is, you know, a nursing home patient sepsis. And the reason being, our protocols for ALS providers, you can give 20 cc's per kilogram for these patients. But what do they really need? They need more fluid. And what we're bolusing here within the hospital, we're using 30 cc's per kilogram. In order to give that volume, you've got to call for medical command. Also, you may, if you're traveling a distance, if we have some folks coming from maybe the Hazleton area down to Lehigh, if the patient is not responding to the fluid boluses, they may get command for some type of oppressor, whether it be the epi-push dose or dopamine. A lot of times you may not want to use dopamine because what's one of the side effects of dopamine? What does it cause? Tachycardia, and the patient is probably already tachycardic. So that's the reason we're telling folks to call in for medical command. We talk about EndTidal Co2, and it's a non-invasive outcome predictor for suspected shock. And we know that for these patients, EndTidal Co2 performs just as well as the serum lactate. So we're not using point of care for lactate levels. We're using EndTidal Co2 for those patients. We've asked the EDs at Cedar Crest and Muhlenberg to increase the stock available for replacement for you guys that are monitoring EndTidal Co2s. So we definitely should have that increased. And it's may provide a method for earlier identification, and so you can intervene with that patient suspected shock. So that's one of the things we're going to add as another vital sign for you along with your temperature. This is just real quick. There were a couple of research studies that were done. This is an urban emergency department looking at severe sepsis patients. And it was EMS versus the non-EMS patient outcomes. In 1 year, they had 311 cases of severe sepsis patients. 52% of them were transported by EMS. We're about 50% here, so you know that correlates fairly well. And what they found out, patients cared for by EMS had a reduced time to early goal-directed therapy by 41 minutes. So they went, the ALS provider, good history, good physical, EndTidal Co2, temperature, IV fluids, they were given their boluses. And as a result, those same patients had a 35-minute reduction to administration of antibiotics. So what we found out was really something pretty simple, that simple, inexpensive changes done with EMS can truly affect sepsis care for that patient within the hospital. Here's another one that was done, Urban Hospital, Pennsylvania, 216 patients transferred by EMS. Of these patients, severe sepsis, there was a 24% mortality rate. Vital sign abnormalities common. 25% of these patients transported by EMS had systolic pressure less than 90. And they found out that serial vital signs by EMS were either not taken or there was poor documentation done on the part of the EMS provider. 30% of the time, EMS started an IV on those 216 patients. And I think that comes out to roughly about 60 of the patients had an IV started and 156 did not. Less than 1/3 of these had the volume that was infused documented, and the average number of cc's delivered was about 316. What are we asking you folks to do? 2,000 bolus, 500, reassess, bolus again, bolus. So we can see that this is far below what really should be delivered in the pre-hospital setting. So of this, we know that of this study that was done, only 38% had an IV established. 8% of the providers documented a problem starting the IV. So what happened to all those other patients that did not receive an IV? In severe sepsis without shock, cardiac monitoring was done less than 50% of the time. And so the author, what he concluded was interventions, cardiac monitoring, serial vital signs, fluid resuscitation occurred in less than half of the severe sepsis patients transported by EMS. Can we do better? Absolutely, okay? So this sheds a lot of light on the importance, the value of the EMS provider themselves. So what are we asking you folks to do? We're going to want a handoff report to the ED nurse. We have the cards made up, so everything that's on this slide is on that card. What's really important is you find out, has there been any recent infection or antibiotic use? Do you know what a possible source of infection is? If that patient is febrile, they're a little tachycardic, breathing fast, and they say, I've been going to the bathroom, quite a bit, or I'm seeing some blood. Dig deep down, find out, ask more questions, find out what's going on. Mental status. Find out what their baseline mental status is, as well as what their current is. And a lot of the nursing home patients, when they become septic, they become agitated, confused. Find out from the staff, if they're around, what the baseline mental status is like. And we also want to know, are there any allergies, including antibiotics, weight in kilos, how much, real important, because I know nursing wants to know how much fluid was infused. And that's something that we're tracking here internally, how much IV fluid. What IV catheter size, what your glucometer was, and all the treatment that you did. So this is what the card itself looks like. And hopefully, you folks will find this very useful for you in your practice. So at this point in time, any questions for Dr. McCambridge, Dr. Niehaus?
Yes, sir.
Mary Ann, so what will the emergency department response be when EMS calls in this suspicion?
So you'll be calling in for medical command report, and Dr. McKenzie, all your physicians are aware that they're calling in. They may say, just continue what your treatment is, or you have that patient who's, refractory to IV fluids. You know what? Go ahead and let's start this on. Increase your fluid bolus to 30 cc's per kilogram, or they may just say, okay, we'll see you in 10 minutes.
Are they mobilizing any team or?
Oh yeah. You want to touch on that? While Rick's making his way up here, a couple of important people walked in during the presentation. Reza is sitting in the back of the room. He's been very instrumental in helping getting this going. And Nikos, our medical student, is in the back of the room. He's going to help us study this.
I'm Rick McKenzie. I'm the Vice Chair of Emergency Medicine. Is it on? Is it on? No, it's probably better with that. It's on. It's on. All right, I'll go over here. I'm Rick McKenzie. I'm the Vice Chair of Emergency Medicine. I've been working with this. And we just presented this to the emergency physicians. So there will be some learning curves as we go through. I probably got to about 20 to 25 of the emergency physicians today, and we will be doing this. We'll all be learning together. So forgive my staff if they don't necessarily know right away what to do. But what we're trying to do is that the sepsis, we're going to probably have a code sepsis, that is the hypotensive sepsis person. That will be a response that we will announce overhead. We'll also group page that so the ICU attending, triage ICU attending will know immediately that that patient's in there, and then they'll think about their resources and what they need to happen. So the hypotensive sepsis patients we're going to jump on. The one that is possibly, because you can see, and all of you have been out there, people with fevers and tachycardia, there's tons of them, and they're not necessarily that sick that you bring in. But if there is somebody that is a suspicion, we'll listen to what you have over the radio, and we will mobilize more attention to that area, as it were. It won't be an overhead. It won't be like the stroke alert or the MI alert. This is kind of like, it's kind of like the strokes in some respects, because sometimes we have strokes that are fairly minimal in symptoms, but we pay attention to them a little sooner. You're not willing to call it a stroke alert. I'm not willing to call it a stroke alert. We'll pay attention to them sooner, but we get that heads up. So I think that's the important part. That answer your question?
Sir.
Looking at the vital signs, cardiac criteria is showing this hypotensive. What about the patient
Yeah, that's a great question.
Do you see it that way also?
Yes.
Yeah, we actually work that into our algorithm. If they're a hypertensive individual and they drop by 40 points or more, we're going to consider that hypotensive.
Right. If their systolic drop by 40, that's hypotensive.
Sir?
So it's important to know what they live at. That would be an important piece of information for you to gather.
Sir?
Pre-hospital, what was the process?
I don't know where we really stand on that. Pre-hospital blood drawing.
Okay, so there are some facilities that are accepting pre-hospital labs. We don't at this point because it's a chain of custody type thing. Maybe in the future it might, but right now, there's a pretty good correlation between your EndTidal CO2 readings and the lactate levels. So at this point in time, the labs will be drawn in the emergency department.
And I would say that what's going to happen after we start this is every 2 weeks we're going to meet. There's going to be a big group of us, and you're going to have representation as well. And we can talk about all these things. Bedside lactate has been a big one that people have been interested in that topic that you just brought up. So we can keep on readdressing these things. We're just trying to get it off the ground right now.
And even the EndTidal CO2 is a new piece that we're bringing into the equation as well. And that's going to be good too. So you'll have that.
Sir?
Related to the vital sign question, on this and on the slide, the blood pressure actually was not a criteria other than being actual fluid assessment. So if we have someone that's still more intensive with the meeting the other criteria, are we still giving them the whole
Yep.
fluid?
Yep.
So,
Yep.
Yeah.
Back up at 100, you're already over 100. Then what do we get?
Yeah, so we're hoping that you start with 500.
Yep.
Start with 500, and then hopefully you'll be calling us. And then we can talk about it. We can all talk about it together. It's exactly what you just said. I think this person's septic. Because honestly, septic shock, one of the problems with septic shock is not quite as clear as some of the other things. Myocardial infarction, stroke, this is a little bit trickier than the other ones. And we know that from when we look at the literature, 90% of the time we're right, we're all right. 10% of the time, not so much. So it's okay, give 500 cc's, give us a call, and we'll try to work through it together.
So this will be medical command. You're giving them a heads up. You're giving the fluids. You're starting the fluids. And we'll all make a judgment from there.
One of the other questions that has come up with the EMS provider is you have that elderly 74-year-old female. She has 2 of the SIRS criteria. You have a suspected or known infection. And, they are normotensive, maybe a blood pressure of 120. The question is, can I put that patient in failure, congestive heart failure, by giving the bolus? And, I think it's easier, Dr. McCambridge, you said it's easier to diurese a patient than, to do, a resuscitation with organ failure.
No, yeah, we realize you're on the front line, and you got all different types of people, and you often don't know much about them. Same issue with us when we're in the ICU or in the ED. So that's a real risk. But what they're teaching at North Shore, Long Island, and it's held them well for 7 or 8 years now, is that it's an interesting thing, and it stuck with me when we were at the IHI, is you can treat heart failure, you can treat renal failure, but you can't treat death. So let's say you're wrong. Person actually has heart failure, they don't have septic shock. We can intubate them, you can intubate them, we can take care of them if we're wrong. More often than not, though, when we look at the charts, we're wrong the other way. We're not identifying in a septic shock, we're not resuscitating enough. And that holds true with that research that you showed about 300 cc's. And we pulled 100 charts in the ED. This is independent of you guys, and we found that was our problem in the institutions: underdiagnosis, under-resuscitation. So if I were you and you're not exactly sure, start with 500. If you have a little old lady from a nursing home and her urine's foul smelling and she looks ill and she's 80 over 50 and you're in Palmerton, then we're hoping that 500 to start, another 500, another 500, and then maybe even the fourth 500 by the time you get here.
Yeah, so I think one of the things that just to give you the polar views on this, we would have that patient that has got a fever, they're tachycardic, and you really don't have a site of infection or anything like that, or you're starting to say they have some pain when they pass their urine. You're going to let us know, and you're going to get the 500, and we're going to talk to you when we get there, and we'll do some assessment when we get there. That's kind of the one thing, but we'll be attentive to that, bring our attention up to this because this is a big deal. Other end of the spectrum, You tell us you got somebody there and they got an EndTidal CO2 of 25, they got a temperature of 103, and their blood pressure is a little on the low side. And we're going to say, okay, give them another liter. Give them this. Let's get that fluid going. So by the time you get here, we may even be close to 30 cc's per kilo by the time you even get here, even in a short transport time. So that's what we're hoping, that we're going to get heads up, ahead of the game, just like we talked about with MI alert and stroke alert. So that's what we're hoping.
Sir?
Has there been any thought as far as outreach to like the nursing home? My concern, I see Mary Ann giggling already. My concern is a lot of the calls that I respond to get into the nursing homes, these people are already circling the drain.
Yeah.
And the question to staff, they've been seeing these sick patients with the same sick symptoms for 24 hours, 36 hours, and we asked them, why didn't you call 24 hours ago?
Well, I'll take a stab at that one. So you're 100% right. You're 100% right. We're starting with you, but the next phase, there's multiple other phases to this, and I think you can actually help us in that, and by giving them kind and gentle feedback. I think that's the next step in all of this is you're on the front lines, and then I don't think it's wrong to maybe give some nice directed feedback while you're there, and give them a button, for goodness sake. Tell them what we're trying to.
You have.
Yeah. Tell them what we're trying to do. Tell them what we're all trying to do for the people in our community. Any other questions, sir?
You just mentioned something that just kind of in Palmer can have a community hospital.
Yep.
You bypass them to bring this patient to meet your criteria here. How do we feel about that? You reached out to the other community hospitals to kind of bring them into the
Keith, you want to handle that one?
Yeah, I think from our standpoint, one of the neat things about our program that we set up for the pre-hospital sepsis alert is that it's not only going to affect patients who come to Lehigh Valley, right? So everybody's going to benefit in the Lehigh Valley who come in contact with a provider who knows how to treat sepsis. So I wouldn't say we want to bypass anybody, and I would apply these same principles to any network we bring a patient to. It's really going to benefit the patient ultimately. And the networks are going to kind of come along with the work that you guys have done. So that's what was really inspiring me to be involved in this. Yeah, it'd be great, we can help patients that come to Lehigh Valley, but we can also help patients to go to St. Louis, patients to go to Easton, patients to go to Sacred Heart, wherever you may end up, maybe Hutton, wherever. They're going to benefit from early fluid resuscitation and early critical care. And really, it's really the handoff. So you guys are trained, but will at least heighten your awareness as to what type of patient could present with this problem, and then giving that to the staff at that particular hospital, and hopefully they respond. I know our goal at the network here is going to be to respond more rapidly. So, and right now I would say no. I think everybody can handle it. If they run into problems, of course, they have referrals to wherever they may go. But that's what I think ultimately will benefit patients. So, make sense?
Somebody else came in the room, but he's wearing a tie, and I didn't recognize him. Jeff Kuklinski is sitting like 4 rows down, a fellow Army guy. I don't think I've ever seen him with the tie on. He looks great with the tie on, but so there he is right there. Okay, how about other questions? Sir, ma'am.
If you have that lab value from that day or within time, want us to report that to you through our verbal report?
Yeah, definitely. And the more information you can gain, and if you can while you're there, tell us about all that. If you can find out if I think one of the questions that would be nice if you could ask the nurses if they know is how's the patient's heart. How is they look septic, how's their heart? Because you're going to be, this is a decision I make every day before I give 10 liters of fluid. up to somebody upstairs in the ICU is I kind of want to know what their heart is. So I think that would be a question to ask. What's their allergies? Does anybody know how their heart works? You know, and that type of thing. I have the advantage of having echocardiograms and all kinds of other things. You don't have that advantage. And that's also something we could probably feed back to you if you're calling in. If it's somebody you bring here often, we could look for you and work together.
Yeah, I think one of the points is you're on the ground floor. Literally, this is the first one of the EMS meetings we have, and we're just starting to roll this out. When we did the MI alert, we had every single one of these questions. What do we do with the nursing home? What do we do with other hospitals? Every single one of them. We have to get this wired first, and then we can really start branching it out. But that's what we're doing. You're on the first step of this process, and it will change, and we'll keep you informed.
Progressive incrementalism. We're starting with you guys.
That's a cool term.
Okay, any other questions? Well, thank you again for the panel up here, for Keith and everybody. Thank you so much we know how busy you are and how this is an important time to be with your families and all. And thank you for coming tonight, and give us a call if there's any questions. Thank you.